So welcome to this, our fifth in the series of Reverse Rett Emerging Gene Therapies bite-sized sessions. I'm Catherine. I'm the Operations Manager at Reverse Rett and parent to Georgina, who has Rett syndrome, and she's 28. It's amazing to be living in a time where there are 2 gene therapy clinical trials underway internationally, and where this year there are 2 gene therapy clinical trials for children projected to start right here in the UK. At Reverse Rett, we have planned these monthly sessions for you, the families and caregivers of people with Rett syndrome, so that we can share the latest information about the gene therapy trials and what we can all expect as things progress with you directly in a format where you can ask questions of the speakers. We do try to keep these bite-sized, which means we start on time and we end on time, answering as many questions as we possibly can. We are recording today's session, so we do ask that you do not make or disseminate any of your own recordings, and we will share this recording with you by email after the session once we've cleaned any bloopers up. Please keep yourself on mute throughout the session so that we can get the best sound quality that is possible. Now we're going to ask each of you to just very quickly flip your camera on so that we can make sure that the people in the room are who we're expecting for security purposes. We know some of you may be working or having lunch. I've literally just inhaled mine, but it's just for a few seconds just so that we can see everybody, and I get to wave at people that I now know a little bit better. See some lovely faces waving back. Lastly, if you do have any questions that you'd like to ask, but you weren't able to send them through in advance, there's a little chat button at the bottom of your screen. As things come to you, just type them in. We'll be collating everything so that we'll be able to ask the questions for you at the end of the session. With that said, I'm now going to hand over to my co-host, Rachel Stevenson. Good afternoon, Rachel.
Thanks, Catherine. It's great to see everyone here. Thank you so much for joining us. I'm Rachel Stevenson, CEO of Reverse Rett, and more importantly, mum of Amber, who's 28, and stepmom to Beth, who's 24, both of whom have Rett syndrome. We know from communications that we're receiving from people with children with Rett syndrome from everywhere in the world that lots of people are avidly watching everything that's happening with these gene therapy trials because everyone wants to know how they're going. I think really it's that we want to see how these patients are doing so that we can extrapolate from that how our own children might fare if, as and when, someday they hopefully will have access to these potential treatments. We wonder about how the treatments might affect the symptoms that they already have, and how they might, for younger children especially, mitigate issues that haven't yet developed. So, as we know, many of the symptoms that our children are living with are these long-term disabilities, but they also often have these complex health needs as well. And for lots of patients, these can sometimes end up in acute situations as well. And so obviously these are things that really deeply affect people's lives. And this would include things like respiratory issues, gastro issues, and of course, seizures. Today, we thought we would really like to focus on seizures, how they might be impacted by gene therapy. And to help us do that, we've asked our good friend, Dr. Jay Shetty, to come and talk to us about seizures and Rett syndrome. So to some of you, Dr. Shetty won't need any introduction. Dr. Shetty is a consultant paediatric neurologist and NRS fellow at the Royal Hospital for Children and Young People in Edinburgh, and honorary reader in child life and health at the University of Edinburgh. Through Dr. Shetty's clinical work, he cares for children and young people with a variety of conditions, including Rett syndrome, and is actively focused on childhood epilepsy clinical research with a particular focus on long-term outcomes. Dr. Shetty was also the primary investigator at the Edinburgh trial site on the Anavex 273 trial for children, which ran from 2021, I think, to 2023. Dr. Shetty, we really appreciate you being here with us today. We're really grateful for the work that you've been doing to look after patients with Rett syndrome and running clinical trial. As you will well know, anyone whose child is affected by seizures is desperate to make sure that they can do whatever they can to limit the child's seizures, to limit the associated risks, and to limit the impact, limit the impact of the medications that they have to take to manage the condition as well. So we really look forward to hearing what you have to say about seizures in the context of this new time we're in, where we have these emerging disease-modifying genetic therapies. Thank you so much for being here. I think that's the longest introduction I've ever done. It's really nice to have you here, so thank you.
Thank you for this kind introduction, and thank you for this invitation. I'm really pleased to be here. Actually, it's quite nice to speak to people. So can you see my slides okay? Yeah, and you can hear me okay. Good. So what I'm going to do today is that I will first and foremost to discuss about any disclosures. I do not have any commercial disclosure to declare in relation to Rett syndrome clinical trials or any of the commercial companies. But however, I will not be able to discuss any of their protocols yet because of the confidential disclosure agreement I have signed. So also that any of the external fees I collect from other educational or commercial activities, and I either donate to charity or use it for undergraduate teaching. So I can speak without any conflict of interest. So what I'm going to talk today, I'm going to talk a little bit about experience from other trials I've been involved. Obviously, we haven't started the gene therapy trial, and let alone Rett syndrome. There are not many people can say for sure this is how it is going to be because this is a new territory. But I will speak a little bit from experience from other trials. I will not speak much about the gene therapy trials, mainly because I watched last 2 to 3 bite size recorded, and there are wealth of information from your talk, Rachel, and then Dr. Dan Lumsden's talk, and then the Taysha representative's talk. I would really recommend those who have not listened to these bite size talks to go and listen to them. Not only just about the information in the talks, but also some of the really good questions have been asked during these sessions, actually. I would recommend that. However, I will talk a couple of points which are probably not covered in those things. That's including CNS, how the treatment delivery directly into the brain. Then, as Rachel mentioned, I'm going to talk a little bit about what's epilepsy and within the context of clinical trials. That will be my overview of the talk. So any access to new treatment is the clinical trials only. So there's very, very rarely you get access to treatment to clinical trials. And also clinical trials are the first access to treatment. That's one of the things which, one of the areas which I work with is rare disease. That's the first access to treatment. So in the process of the discovery of a new treatment up to the post-marketing surveillance studies, clinical trial happens to be in the first access to treatment. So as I mentioned, I will not be talking any more details about gene therapy trials, but I would say there are some common themes to all these talks. This is a very exciting time, really exciting time, that if somebody asked me 5 years ago, is this where we are going to be? I would say no. I wouldn't think that how fast we would be here, actually. That's a really exciting time. But there are also some things are unknown. It's really important that managing the uncertainty and unknown facts about these things are very, very important. And that's why these kind of communication and bite-sized talks are really important. And the third factor is that this is this primarily safety trial. So it's really important to recognize that the phase 1 and phase 1 and 2 trials are primarily safety trials. Obviously, in gene therapy trial, there is no healthy volunteers. There is no pure safety trials done before the patients group tested. But this is a primarily safety trial, so it's really, really important. I'm going to mention this again, which I mentioned in my previous talks. Sometimes things can go wrong. It's really important to recognize in the new treatment trial. This is one of the healthy volunteer trial a long time ago actually, and the people become unwell. So that is why what I would say to the community is that when you are participating in the trial, do read all the information, everything which has been sent to you. That could be sometimes many pages, and do ask questions. It's really important. This is primarily a safety trial to start with. So there is quite a bit of information in Dr. Bennett Murray's talk about setting up the trials. I will not talk about all those things, including trial sites, investigators, protocol changes, approval, and training. But a couple of things I'm going to mention. In terms of the investigators, there is not going to be any investigator like me or others who would be very experienced in delivering gene therapy trial. That is why there will be a committee set up at each site to assess how well qualified are we to deliver this trial. So there will be organizations looking into what kind of support we will need as principal investigators, because at the end of the day, at the trial site, as a principal investigator, I'm responsible for conducting the trial safely and effectively. So there will be an assessment of the investigators. And then there needs to be several standard operating procedures. To give you a small example, so with gene therapy is a genetically modified virus will be used as a vector, for example. And for example, this is be done in an operation theater. How we are going to dispose of all the wastes from the operation theater when this trial is done, for simple things like that. So we are going through lots and lots of simple but very important standard operating procedures which are needed specifically for this trial. And that's why it takes a significant amount of time, because everything which we need to do is done in a clinical setting, but we need to make sure that there is no safety issues. And
But do you reckon I'll be able to get late then?
So then, unlike the other trials, there are some issues with regard to specific approval. For example, we need to, for any other clinical trials, we will get a R&D approval and the local governance approval. But here, we will need to have a gene therapy approval. So then once we submit the application to the local committee, they will have to form a gene therapy assessment committee, and they need to go through every single paperwork. And then they need to assess the team, the place, and the safety of those things. That's another one. And there is another committee called phase 1 study, or first in human study. So every treatment which is first in human needs to be separately assessed by a first in human study. Again, they will go through the same thing, the place and the staff, and are the staff qualified to deliver these things? Are the staff qualified to deliver in the activities which are needed? For example, can we do safely lumbar puncture under general anesthesia or without general anesthesia? Or can we do we have the neurosurgeons qualified enough to do these procedures to safely administer the treatment? And then, because some of these rare disease trials where you need to look at certain parameters, for example, I've been involved in a trial on dyskinetic cerebral palsy where you needed to look at certain movements, whether this will improve after giving the medication, and the sponsor wanted to independently assess a video of these participants. Now, what happens when we want to send an information outside our organization which are identifiable? Then you need an information governance approval. So you need a GDPR assessment for that. So these are all the process which will take a long time, and then obviously this will be assessed. Sometimes they might say this is too much information, and where will this information be stored, how it is processed, and various other things. So there are several other approval processes are necessary, and it is really important to do these things, and that's why this is taking much longer than we get other trials started. I'm going to talk a little bit now, shifting gear into so one of the areas is that how we can deliver this treatment. There are two routes of delivery of the treatments which are talked about. One is the lumbar puncture, which is basically a spinal tap, and the other one is directly into the ventricular space or the cerebral ventricular space. You can see that the two diagrams I have, three diagrams. One on the top is where the lumbar puncture is done, which is a very common procedure in the neurology or in children's hospital. It's not an uncommon procedure. But within the context of Rett syndrome, we need to think about a couple of things. For example, are there any spinal surgeries or those kind of things? So would that have any implications on that, or is it easy to do that? Maybe an assessment necessary. That's really important to think about that. And likewise, for example, in the bottom two images, I've got one image which is called black space and the catheter goes into that. That is a condition where we put a catheter into directly to the ventricles, where this neurosurgeon makes a burr hole through the skull and then they'll put a catheter. Now, you can see a red circle there, that's where the catheter sits. But that is a case of what we call a hydrocephalus, where you have already a larger ventricles or the bigger fluid space inside the brain. That is the main reason for doing this catheter. But in people who do not have this condition, on the MRI picture next to that, the fluid is white, you see these ventricles are normal shaped. So an access to these ventricles are going to be possible, but it is not as easy as someone who has got a larger ventricles. So obviously our neurosurgeons are skilled in doing this. They use a navigation system in the operation theater to access these things. So these are the practical things we need to think about when it comes to these things. Many of the trial sites in the UK have plenty of experience, and I can speak from our side. We use what is called an intrathecal baclofen in cerebral palsy, which is a medication which goes into the spinal space. We've been doing this for many, many years. Likewise, delivering antibiotics directly into the ventricles, and more recently, SMA treatment, spinal muscular atrophy treatment are delivered through lumbar puncture. So there is plenty of experience, but it is important that these procedures are all operative procedures. These are not without any risks, are not without any problems. And then all this is done under general anesthesia. Obviously, the child will not have any pain or discomfort, but then we need to think about the anesthetic complications. Are there any respiratory issues or breathing problems or other things? Then we need to think about all those things. Those are the aspects we will be thinking about when we are considering inclusion, exclusion criteria and various other things. So then I'm going to mention a word about the clinical trials and NHS at the moment. It's really important, and I thought I would just kind of spend a minute or two on that. By far, I've been working in NHS for 24 years now, actually. By far, NHS is the ideal place to run these clinical trials. That is because all the patients are seen in the NHS settings, and each of the NHS hospitals have their own records. And even if you move from one area to another area, you can still get all the data from one place to another place, and it's easier to communicate, and there is a safe and secure transfer of data within the NHS setting. So there are several advantages for running the clinical trials. There are also several advantages for the NHS because they will have an early access to this treatment, and then particularly preparing these complex trials when these treatments, if they become approved by the regulatory authorities, when they become standard treatment, then we are already prepared for these things through running through clinical trials. There are several advantages. However, it is very important to think that you all know this very well, that we are going through currently some challenges in terms of how we deliver care or on a day-to-day basis, and our long waiting lists and other things. So this might bring some challenges in terms of availability of theater spaces, anesthetics, and those kind of things. It's really, really important to take this in the context. Okay, now I'm going to share a couple of experiences. I've been in clinical trials for nearly 25 years. Ever since I left medical school, I worked initially in WHO and then several clinical trials. But mostly over the last 12 years or so, I've been largely involved in clinical trials in the rare neurological disorders. I've been running clinical trials and still run clinical trials in MS in children. It's a very rare condition. I've been involved in rarer epilepsies like Dravet syndrome and Lennox-Gastaut syndrome as a co-investigator. As I mentioned before, dyskinetic cerebral palsy is, and again, a very rare condition, and other rare neuroinflammatory conditions like Aicardi-Gouttier syndrome, and obviously the Anavex trial. Now, I've highlighted the rare epilepsy and Aicardi-Goutieres and Rett syndrome is because these are all kind of similar in trial setup, is that patients have complex health needs sometimes. There may be seizures, respiratory issues, mobility issues, and complex, sometimes complex disability related things, and behavioral problems sometimes. So these kind of things are all common to these group of conditions. So we do have some experience running these trials, and that's important. And I will give you one example from a couple of conditions. This is a trial which when I started looking after young people with multiple sclerosis, which is a rare condition, thankfully, they had only regular injections as their main treatment. In 2015, I got involved in this international trial comparing an oral drug and an injection. You can see on the top line is the percentage of the people who did not have any relapse on the new treatment, which is an oral drug, compared to the line below is the percentage of people who continued to have relapses in spite of being on an injection. That means to say we had a far superior treatment thanks to the clinical trial. And since this trial is completed now, we have been running other trials in children with multiple sclerosis, and I do not see any more relapse. I used to do a relapse clinic before. I do not see any more relapses. So clearly, these trials are complex to set up, but clearly there are clear benefits out of this. But I'm also going to show you another trial, which I've been a co-investigator, which is a cannabidiol medicine, which is a cannabis-related compound used in some complex epilepsies. This was a very difficult trial to set up with, and there were lots of interest because cannabis, a compound as a available treatment for epilepsy, gathered lots of public and media interest. But it is very, very important that, which I'm going to again show you the data here. This is the this is not a regular cannabis available on the street. This is the cannabidiol treatment, or it is or the unlicensed medicine. This is a chemical which is used for purely epilepsy treatment. So there's two groups here. One is the cannabidiol group, one is a placebo. That means along with their standard treatment, they were given either cannabidiol or placebo. So this is the number of convulsive seizures. That means the number of seizures they had at baseline. They both had 12.4 seizures per month and 14.9 seizures per month. And during the treatment period, there is a 5.9 seizures per month. That means there was a significant reduction, but it is not completely stopped. But you also see that the placebo group also had a significant reduction in seizures. And it's really important to think about the placebo effect in the clinical trial. While participating in clinical trials, you see a number of benefits, and you got to be careful whether that's a placebo effect or the treatment effect. So that's the point I wanted to highlight actually. For a small number of children, this has clearly helped, but it is not as much as the publicity you see on the media. And then obviously there are a lot of newer treatments in Dravet syndrome. Currently there is an antisense oligonucleotide trial, which is kind of similar to a gene therapy trial really, which is set up with an intrathecal treatment. And the results of these treatments are not out yet. It's still an ongoing trial. We are one of the sites. But there are things we learned in terms of the screening baseline period and all these things from this trial will help us in other trials. We were unable to recruit to this trial as there's very few patients in this disease group, but there are several things which we learned from this, particularly getting assessment from the phase 1 committee and other things are helpful for us for the future gene therapy trials. So as I mentioned, these trials will help us in the gene therapy trial, although we do not know how this is going to be, but we can learn from the previous trial. And particularly about the screening process. Say, for example, somebody gets a screening, and then there are lots of things to think about. For example, as I mentioned, seizures are one part of the things. For example, if you're screened and then if you start having lots of seizures and you need either go to the hospital or needed to change lots of medication, and then you may not be available at the time of the baseline visit, or the seizures may interrupt your trial participation and other things. So in specific to epilepsy, that is one of the things to think about, is that how well controlled are the seizures, and what does the seizures do. But it's also helped us because we could learn from each other in terms of trying to set up who had kind of within the UK, all the investigators, we work quite closely, and we can learn from each other in terms of what helped. We also learn from challenges for the patients and the families, and it's really important that it's crucial to participate in trial, but their life happens as well. You might move job, you might move from one place to another place, or your or siblings or the other people may have health problems, or something else happens, or all those practicalities need to be thought about. And there are lots of visits to the hospital, not just for the trial related visits, but if you have any other health problems, for example, during that time, that needs to be reviewed. In another time, you may not get reviewed in the hospital, but that needs to be reviewed. So there are lots of practical consideration as well. And the seizures are quite important aspects in this. That's why I kind of mentioned about seizures several times, that when you have seizures during the clinical trials, you would want to think, are these seizures likely to have happened without the clinical trial component, or is it related to the clinical trial, or is it related to the aspects of being unwell, or sometimes we see an increased number of seizures during infection or puberty or something, some other trigger factors, for example. What are the reasons for this? So these are the things to keep in mind, and documenting the seizures, which I will talk a little bit more about, is quite crucial. So a few years ago, one of my research students, Megan Hutchison, did this really helpful work of a qualitative trial in recognizing the seizures for children who have intellectual disability. So we basically recruited few families from different conditions, and we wanted to know in depth why this qualitative study, because it is really difficult to collect the information in other way other than doing an in-depth analysis. So I will share this paper. Actually, it's quite useful reading, and we had few parents participated, and it's given us a really good insight into how our understanding of seizures, which can mimic normal movements sometimes in children with Rett syndrome and other neuro degenerative conditions. So in one of the theme is that knowing what is normal. So only the parents will know what normal is actually. Sometimes you go to the hospital and someone might recognize that as a seizure. They may not know what normal for a young person is, for example. So knowing normal and being in tune is something, a key theme comes in again. So it's really important to listen to parents when they go to the hospital. This is not normal. You cannot dismiss this is not a seizure, or this is seizure. This is being in tune with the families is the key things. And the seizure recognition is different by particularly mothers and the healthcare professionals, and the eye changes particularly in some of the conditions with intellectual disability is quite a crucial thing. And then coexistence of epilepsy and rare neurological disorders. Nature of the seizures, not everybody has this experience, so it's only the parents who know this very well. So she went on, here I've got some themes from some of the parents, which is, the quotes are powerful. So knowing what's normal, one of the quotes, it says, the people who are closest to her can recognize them more than the people who haven't seen much, even the relatives and friends. So that's a crucial part in terms of recognizing the seizures. And there was one mother whose daughter has Rett syndrome, explained, it's a change in stare. Despite her daughter having difficulty in moving her limbs, no speech and erratic eye movements, the mother was able to recognize the change in her that allowed her to identify potential seizures. So these themes come repeatedly again and again. It's really important for the investigators and others to keep in mind what are seizures and what are not seizures. Based on this paper, we recommended that it is really important to consider videos as a crucial element in this recognizing these seizures. And epilepsy is very common in Rett syndrome. It's about 60 to 80% of children with Rett syndrome can have seizures, and particularly early onset epilepsy can be less favorable, particularly for treatment. It's very difficult to diagnose, as we mentioned, for the reason, and the seizures can mimic some of the normal movements, and people can miss seizures easily. And it is very hard to do EEG in all the children because children do not like EEG leads being put on them, or they might throw it away after some time. So longer EEGs are very difficult. I think videos are very crucial in Rett syndrome. Treatment can be very challenging. There are many triggers for seizures. For example, sleep problems, tiredness, infection, puberty, other unknown factors. So there are many of these things can be quite significant. And within the context of clinical trials, it has an impact on screening. We need to understand whether there's an interaction. Particularly with the new drug, we will not know much about it, whether there was a previous interaction or not. We need to be carefully thinking about these things. What was the seizure history? What was it before? What is it now? And then we need to report every single adverse event. One final word about the treatment recommendation. I believe we will be discussing quite a bit more in epilepsy in your event in June. But this is one of the one of the review done by my colleague in Bristol, Dr. Sam Amin, is the treatments used in Rett syndrome and what has been the favorable treatment. Sodium alpurate has been mentioned in more papers than others, but you can see there is only 3 guidelines mention sodium alpurate, but there are several other medications. But it is also important that these treatments can have an interaction in terms of behavioral change, tiredness, day-to-day life, lots of different ways. And when you combine these medicines, more than one, there can be more significant problems. So this is clearly an unmet area which I will be continuing to look into and do a bit more research about this, because I think this is a crucial aspect which we need to think about going forward. So how can you help? That's kind of giving you a little bit about seizures and some of the aspects of the trial team which has not been covered. I think it's really important that these trials are going to be complex. There are several factors, including seizures, one of them, and having known where people are and what their current status is and who's able to participate in trial, who has interest in trial, I would say registering through the Rett registry is one of the crucial aspects, and I cannot emphasize more about this, and I'm sure several messages have been, and I really admire those people already who registered with these things, and I think your organization is probably way ahead compared to lots of other organizations. And then sometimes we have a trial comes in and we set up the trial, we do not have enough people to express interest in the trial. But I think in Rett syndrome, you're certainly quite far, but I think it's important to recognize this, and then more people registering through Rett registry is quite crucial. So I will stop there, and I would want to thank you for being here, and thank you for giving me this opportunity to share bits and pieces of information about the trial itself and some of the issues around setting up the trials, and particularly thinking about seizures and epilepsy and within the context of clinical trials. And I'm happy to discuss this further or answer any questions. Thank you.
Great, thank you, Dr. Shetty. That was so interesting. And I'm really glad as well that you mentioned at the beginning of your talk that just to highlight the fact that we, of the current gene therapy trials that are taking place, the information that has come out about the first couple of patients on the adult trial, these are initially safety trials. And so that's part of the reason why we at Reverse Rett don't necessarily go into great detail about much of the information that's come out from current trials about the kind of efficacy stuff that's come out, basically. I think some of the things that I found really interesting were when you were talking about some of the reasons that these trial sites take a long time to open. So I think a lot of the families when they see an approval, an MHRA approval come in, or an FDA approval, they think, okay, you know, I certainly do. When's this going to start? Like, hurry up. And when it takes many months, people, yes, we all understand, okay, there's bureaucracy and there's things to organize, but it helps to have tangible things like knowing that you need to have these standard operating procedures for, say, the operating theatre, or understanding that the need for general anesthetics and things like that at different points in the study will impact the study, the site being activated. The other thing that I was really grateful for, besides you obviously mentioning the Rett Registry UK, I was grateful that you mentioned how important it is to listen to the families and being in tune with what families say, and giving the validity to the people that spend the most time with the patient, child, young person, or adult with Rett syndrome, or any other condition. And so that's really appreciated. I think that the number one question that I think I've heard from families who have children with Rett syndrome who have seizures is, will people who have seizures, whose seizures aren't completely controlled, be able to participate in clinical trials? I mean, would they even be excluded immediately by inclusion-exclusion criteria? Let's just speak generally. It's not just about the gene therapy trials, it's about any clinical trials.
No, that's a really good question. The simple answer from experience with lots of different clinical trials, including epilepsy trials, is that obviously, you'll not be excluded as long as your epilepsy, for example, we have had other trials with the cardiac syndrome or other things, as long as your seizures are reasonably stable. So you expect it to be stable epilepsy, for example. And I would hope that will be the same for the gene therapy trials, because you cannot exclude people for a trial where seizures are one of the common symptoms. But I think there will be some specific instructions about what will be the seizure related things when we have the full details about the trial. But certainly from my experience with other trials is that it's not excluded, same with cerebral palsy trials and things like that. But there are some, you would be able to participate in the trial. For example, if you have a very unstable epilepsy, if you needed to go in and out of hospital quite a bit, that makes it very hard to be participating in a clinical trial on a practical level, let alone for the trial purposes, even for the family's purpose.
So thinking about people then who have children in the age group, the relevant age groups, who might be interested in participating in any clinical trials, if they were in a situation, because as we all know, when you've got someone with Rett syndrome in your life, sometimes you're choosing between the rock and hard place of management with medications or kind of quality of life in terms of the symptoms, particularly things like the person becoming more sleepy and so on. I suppose, is it a question? I'm not sure. I think what I'm trying to get at is the emphasis maybe is on, if people want to take part in these kinds of trials, getting the person as stable as possible as a priority rather than.
Yeah, I mean, I think even if not for the trial, it's really important. I would think that speak to your clinicians to make sure that your epilepsy is well treated. I mean, it's really important because obviously in any neurological conditions with epilepsy as a secondary symptom, it is very important to get epilepsy more stabilized. The reason is that if you're having more, albeit short seizures, you're less interactive and your quality of life is poor. We know that from many other trials. I would think that it's really important to consider epilepsy treatment and stabilizing epilepsy, and recognizing, particularly in the prepubertal girls, is that there can be an increase in seizures and everything else. A bit more proactive about seizure management and everything is very crucial. And I would think certainly that will obviously, if you're stable in epilepsy and if you're eligible for the trial, and that might help. But even otherwise, I would think it's a good idea to just get epilepsy well managed.
Yeah, and I think I just will tell you that there was a time where, for my daughter, where she'd first started to have seizures and she was put on carbamazepine and she was just zonked all the time. And I kept going back to the doctor and going, she's really zonked, but her seizures are controlled, or, and he had to actually sit me down at one point and go, the goal is management rather than complete eradication of the seizures. And that was a bit of an eye-opening moment for me. So, but I think there are people out there who maybe you end up on that continuum of not treating it as much because you're trying to keep some of that. It's just a fine balance, isn't it?
Absolutely. I mean, partly true, and partly it is finding out. I mean, this is where we are moving away from a condition-related treatment to individualized treatment. This is where we need to collect more data into say what worked well for some young people with Rett syndrome in epilepsy compared to the others. And what happens is that all the drugs which I mentioned in the list are all very kind of quite significantly older anti-seizure medications. Are any of the newer anti-seizure medications are any beneficial? Or obviously certain combinations of medications are beneficial in terms of stop preventing them being more sleepy or more tired, or are there any other interactions with any other drugs and those kind of things. I think this is one of the area which certainly it's a very under researched area. I think seizures, particularly given that how frequent the seizures compared to, say, for example, if you take Dravet syndrome or some another condition, there is very little. We are in it's a Dravet syndrome. We are in a stage of a separate gene therapy like treatment for seizures control alone. So our understanding is very poor about this actually, and I think it's really important to look at something and see what is the right combination of medicine and what are seizures and which seizures get better, and is there a way of monitoring this through videos rather than like listening to somebody someone from the school, for example, say, oh, not had any seizures today, but by the time in the evening you're quite exhausted, or had lots of seizures. They may not be seizures, may be related to behavior. So I think this is one of the area which probably we need to really look into that. So it's not this is beyond gene therapy trial is quite important as well. The reason is I'm saying is that once we have gene therapy trial which improved, say for example, significant other function, but if you continue to have seizure, then that in itself is a significant comorbidity. So we need to have a proper plans to think about seizure management.
I think that's one of the things with Rett syndrome, isn't it? It's almost like each one of the symptoms for different people could itself just be a disorder of its own. It is a disorder of its own, and it's a whole life thing that someone has to deal with. Catherine, did you want to ask something?
Yeah, I would just, my daughter doesn't have epilepsy, so I know I'm one of the 20 lucky %. But I'm thinking we have a lot of very newly diagnosed parents who are coming to these bite-sized sessions. What would they be looking for? Could you sort of give us a few pointers so that if they notice, because we all know that, that the girls can be quite trembly upon waking, or they can, have what I always used to call little retisodes, where, she would just kind of go into power down mode for a few minutes and then kind of come back. But what should parents be looking for?
So by far obviously in a very early epilepsy and the first 2-3 years of life, it's fairly obvious is that you're likely to have more generalized seizures where you have a proper convulsion. But by far in the later age group, it is the head drop or sudden stiffening. Sometimes it's sudden stiffening moments actually, and then head drop is not just about just being tired. It's just kind of the sudden drop, like just a sudden drop. I will hopefully probably at some point we will run a session where we can look at some of the videos of these things, but it's these subtle movements and a subtle change in the staring and subtle change in the interactions. And then you can have these seizures called myoclonics, as if sudden shock like things. Actually, these things are very small but have a big consequences, in the sense if you're having multiple times these seizures, that means that much time you're not interacting with somebody. Sometimes we always think about big seizures, but the big seizures are maybe less frequent. The convulsive seizures are maybe less frequent. It is the muscle stiffening, which is kind of, which can sometimes mimic with what we call dystonia or the spasticity, but these are episodic in the sense it looks the same every single time. For the seizure, it looks the same every single time. To see the pattern, common pattern in each time, and even when you're used to the regular eye movements, but suddenly you notice a change if there is a fixation in the eye movements. Actually, there are subtle changes to your regular eye movements. Are there anything? So this is where when you're particularly, I mean, parents do recognize it, but it's often others don't actually, or others might wrongly think. This is where videos are helpful to say, this is her normal moment, this is not normal. This is to show somebody, if you're in the school or care settings or something else, to say, do let me know if you have seizures. This is what normal looks like. This is not normal. So kind of noting those things is a crucial feature.
Thank you.
I think that's really helpful. I have 2 more questions, but I'm going to zip my lips and ask Catherine to ask the questions in the chat.
Okay, that's lovely. Thank you. So I know at the beginning you did say that you weren't going to speak too much of the upcoming gene therapy, but we're all human and we're all desperate, so do beg our pudding. And if you're not able to answer it for confidentiality reasons, that's absolutely fine. But Abigail has asked, do we know if there is a possibility that seizures already diagnosed as epilepsy could be stopped as a result of the gene therapy? Or, sorry, carry on. Or once it is an epilepsy diagnosis, is that a separate entity?
I mean, you'd think that epilepsy diagnosis in Rett syndrome is not a separate entity. You'd think this is a symptom of the same condition. And having said, and that's mainly why do we say that is because the seizures are slightly different for the long discussion we had about, sometimes it might look like this and things like that. You would think that is part of the symptom. Having said that, it's really important to have the caveat that people can have epilepsy without Rett syndrome or without any other neurological. I mean, large number of young people whom we see, we have epilepsy, they may not have any underlying neurological disorder. Epilepsy may be the only diagnosis they have. Will gene therapy or treatments will eradicate epilepsy? That is a very, very difficult question to answer at this stage. The reason is that what we do not know is that how much function reversed or improved in human subjects. We have not even, we're measuring at the moment safety, and I think it's very early to answer those questions. Even after starting gene therapy, I do not think we answer that question, is because if someone has more seizures during the trial, for example, that doesn't mean that they will not have future seizure stops. Or if somebody stops having seizures during the trial, that doesn't mean that their seizures will not come back. So I wouldn't think even in the shorter term we will be able to answer a question about something specific to seizures. I think that's unfortunately we are not in a stage to answer that question.
That's fine, thank you very much. Alina has asked, is there a phase 3 of the trials expected, or can we expect the regulatory approval after phase 1 and 2 completion?
Thank you for this question. That's an important question. I guess that largely depends on what outcome measures we see from this trial, from the gene therapy. So because for example, we already have gene therapy for other conditions like spinal muscular atrophy, or there are a couple of other conditions and some metabolic conditions. So if you see a significant improvement, and then obviously regulatory authorities look into that. One of the difference in Rett syndrome compared to other conditions with Rett syndrome, other conditions, is that in here, we are doing this trial in someone who's already established symptoms. And lots of gene therapy trials are going for treatment, someone who's before the symptom onset starts, if you like. So these are all the aspects that will be taken into consideration. But I think it depends on, first, it's important to recognize safety. Is it safe to use this treatment? And then what function it has improved, and how reproducible it is, in the sense, like, what I'm saying is that if two people exactly, say 5-year-old, who have exactly same difficulties go into trial, might have different outcome actually. So in the sense, like, whether we need a larger sample or those kind of things are at this stage difficult to know for sure. Yeah, and then these are the things the regulatory authorities will look at to see how good is outcome and various other things. Phase 3 is, yeah, I mean, largely in gene therapy trials, so far in some of the other conditions, they did not have to go for phase 3, but that depends on the functional outcome.
Thank
I
you.
think that's why we at Reverse Rett, when we kind of give news about the gene therapy trials, we tend to do a kind of, here's the milestones to look for next in the short term, rather than this is what we think will happen in the long term, because as you said earlier, this is quite uncharted territory for, you know, and this is a different kind of condition to some of the others that have gone before. Catherine?
Thank you. Joe has asked, for pre-screening, would you anticipate criteria to include other medications other than epilepsy medication?
So we will probably, there will be list of things will be sent from the sponsors in terms of what medications are allowed and things like that. For example, there may be, if they have noticed any particular interaction in the previous medication or related to that, they might but I do not think there are any specific things we are looking at this stage, but there will be a sponsor inclusion criteria or exclusion criteria in that. There are there may be, but again, in Rett syndrome, I do not see a huge number of different medications other than the seizures and the management of respiratory and behavioral treatments, and these are.
Okay, so Joe is referencing hormones. I'm not sure what you mean, Joe. Can you unmute and just explain quickly?
Hi, yeah, just so you know, a lot of us with our girls find that epilepsy is significantly controlled by the use of hormones like the pill in different forms. And I also, you know, take into consideration that, as we know, hormone tablets, the efficacy is reduced by taking epilepsy medication, especially with carbamazepine. So my question is, you know, when you're getting a combination, so I call for me, hormones work for Clara as an epilepsy treatment. It really helps to control her seizures. And with the interaction of the epilepsy meds, would something like, you know, it's a very broad question, but would that have to be taken away? So she's, you know, in order to be able to be considered to be on one of the trials?
I mean, I can, from a previous experience of other trials, the answer is you do not need to. I mean, as if there is something which controls their epilepsy better, then you would not change such a treatment to make the epilepsy worse. And from certainly involved in previous other trials, that is not needed actually. And then sometimes the hormonal treatments are given, particularly even if, for example, if the periods are quite difficult to control and things like that, if irrespective of epilepsy, then it's one of the standard treatment used in lots of girls. So it's actually not been removed in my experience in other trials. It is not necessary unless you know a compound which is specifically interacts with certain types of hormonal treatment. Certainly, yeah. From my previous experience, no, that's not an issue.
Thank you.
Rachel, do you want to come up with your 2 questions or your few questions?
So my first question, really, leading up from that, actually, this might be the one that I really want to have answered, is I noticed from the thing that you put up, thank you for putting up those journal articles, and we will share them in the show notes afterwards. But when you put that one slide up that was of all of the different medications that are most commonly used in Rett syndrome, it's still apparent that sodium valproate is very high up on the list. And I know from families of younger children that people are trying to not put children on sodium valproate now. In my day, it still is my day, but in the old days, some of the doctors used to say, when my daughter was about 9 or 10, sodium valproate and another medication is very good for if you have seizures like Amber had, which was a lot of different kinds all the time. So we went on to sodium valproate and lamotrigine, but what's the most kind of popular one now? And that's my question really. Like, is there a popular combination now, or is there one medication that seems to be the most helpful?
Yeah, I mean, I think that this is more a general advice, and I do not want anybody to take this as a specific to their young person and things like that. And this is basically where I would say a bit more personalized medicine comes into picture, in the sense we need to characterize what are the common seizure types. Are there any specific pattern if they happen during clusters, during, say, for example, around the time of the periods, or is it a bit more kind of around the time of infection, or is it happens all the time? So it's basically having a little bit of, like making a plan. What are the types of seizures? How frequent are they? Are they more during sleep, or more on awake, or particular time? Are there any specific stressful factors are there? And then speak to the clinicians also what other medicines you're on at the moment. Are you on a treatment which is both these 2 or 3 medicines are likely to cause problems in the liver function, or your hemoglobin might go down, or platelets might go down, and those kind of things. And then look at the interaction side of things. And then which are the medicines which gives you more side effects in terms of more tired and more those kind of things. And then I would say decide the combination. For example, I give you a specific example. If someone has got clusters of seizures just around the time of periods, or when you get an infection, you might think about a medicine like clobazam, for example. It's a benzodiazepine, but you can give it for a short term if only the seizures are happening in the short term. And obviously, I would recommend you discuss with your clinicians locally, because it's all important that take everything into consideration. So. And likewise, I think it's a bit more an individualized management plan. And I've been speaking to you about this before, and I think even speaking to your own members, all of you, and who have had children who had seizures, it might be useful collecting the information to learn from each other to see what worked best and what did not work, and what made seizures continue. That's something for Reverse Rett UK to look at.
That's really helpful, thank you. I mean, we can definitely do that through the registry, I think, and start to track that kind of information. I know that in one of the recent burden studies that was done by either Neurologist or Tasha, they did look into what meds people were on, and they were different here compared to the States. I think I appreciate you giving an answer to that question. And the reason that I asked it is because sometimes people have local clinicians who aren't familiar with Rett syndrome, and then they might have to go on a bit of a trial and error course, which you know what the pathway is, but I think sometimes it can be helpful if they can go forward and go, we've heard with other people with Rett syndrome, or from this meta-analysis or whatever, this is what's being shown to be helpful. But definitely going down that route of personalized medicine as well.
I've got my very last question, then we do have to wrap up because it is 3 o'clock, and I do try, I'm a stickler for time.
It's 2 o'clock here.
Sorry, yes, it's 3 o'clock here. So Maria has asked that her daughter is 4.8 months old and recently started having cluster seizures. Been over a month in hospital. It's lovely to see you, Maria. I hope that Emily is now back home. Well, I saw her, so I know that she's back home. So she's now on Kepler. Can't they call these things normal names? Topiramate.
Yeah.
Thank you. And God, this is a terrible thing to do to a dyslexic.
Phenytoin, sorry,
Thank you.
phenytoin.
Thank you. But she's now very floppy. But is seizure free? And this goes back to what Rachel spoke of before, which is, yes, the seizures are under control, but quality of life kind of has to come into it as well. And Maria's just wondering whether it would be worth her while pushing for a prolonged EEG, even though she's now seizure free.
Yeah, I mean, I think I will probably, again, I do not want to interfere with the local clinicians' management. It's really important about that. But I'm going to give a very general advice about early onset seizures and their treatment, and then how best we plan these things in my experience and things actually. So when you have got very frequent seizures very early on and as a baby, and then you had to use more than 2 or 3 medicines to control them, there are a couple of things happen. As seizures get better, there are 2 things happen. Your body gets rid of the medications a bit quicker with time, so your floppiness might improve. It may be temporary. If that is the case, then it is important to have a reasonably good amount of seizure freedom, so that will help in terms of neurodevelopment and other things. But equally important to not overburden with medicines either, particularly with phenytoin. Presumably you needed to get blood tests and everything else to get the check. Having a discussion with your clinician if there are opportunities. I mean, in the UK here at the moment, the longer EEG is variable. Some units have a long waiting list in getting a longer EEG compared to the others. If possible, getting a longer EEG, that might help sometime in terms of to see how frequent are the seizures and what time are the seizures. And then when you're on more than 3 medicines or 2 medicines, working out which 2 are the best out of the 3 and like what worked better. But obviously when you have lots and lots of seizures, what you basically parents become very anxious and the clinicians want to make sure that the seizures are treated, we use more than 1 or 2 medicines. That is with time to try and think which one of these work better, and has some of these side effects got better, because when you first start the medicine, all of these medicines have side effects, some more than the other, and then which has got the least side effects and been most better. That's a kind of bit of working out, having a bit more discussion with your epilepsy nurses and the clinicians probably. Is that kind of an indirect way of answers your question?
Thank you, yes.
Before Catherine wraps up, can I just say how amazing epilepsy nurses can be and how much we appreciate everything that they do.
Yeah, they are actually, they are kind of the main kind of force for epilepsy management in the UK, and just to give a shout out to them is that since the epilepsy nurses been in role over the last 20 years or so, the number of children getting admitted to hospital with epilepsy has significantly reduced. So clearly they are really good.
Brilliant, brilliant. Well, that's it. Another bite size draws to an end. And I would like to thank Dr. Shetty so much, taking your time out of your very, very busy day to help us all and to just really help explain, having been through the trials, that we need to be patient, and we're finding that very difficult as a community at the moment. But thank you for reinforcing that. Thank you to everyone for joining us today. We're sure you will agree that it's been a very useful and informative session.
Thank you.
You can find links to all the Reverse Rett emerging gene therapy sessions if you're suffering from insomnia and need some help to get off to sleep. Pop on over to the Reverse Rett YouTube channel. Remember to like and subscribe. And you can see all of the past, and I know I'm joking about insomnia, but they are very beneficial, and we really work hard to pull together the experts for you. So if you haven't seen them, do pop over and have a look. So we're very much looking forward to, and I really have to say this with gritted teeth, very much looking forward to seeing you all at the Leap Day in June. Dr. Shetty is going to be presenting at that event about seizure management. In the meantime, thank you all very much. And for those of you who celebrate, happy Easter. My mum brought me an egg today, so I must have been a very good girl. So take care, everybody. Have an
Thank
amazing
you very much.
weekend.
Thank you.
Thanks,
And thank you again, Dr. Shetty.
Bye.
Thanks, everyone. Bye now.
Bye, everybody.